Hi everybody. I am going to talk to you today about what I believe is a very important topic in general, and especially nowadays. There is a lot of talks about the problem of recurrent pregnancy loss. In fact, there has been a lot of buzz in the media about that problem and its impact on couples who are trying to have a baby. By definition, or what does that mean? It means that a couple who have 2 or more failed clinical pregnancy. In other words, you conceive and you miscarry 2 times or 3 times in a row. What's the likelihood of this happening? Actually, it is a very common problem, and it happens to 10 to 15% of all couples who are trying to have a baby during their reproductive years of life. This is what's called sporadic pregnancy loss. But when you look at the incidence of recurrent pregnancy loss, which means 2 or more in a row, it's about 1% of all women during their reproductive years of life will suffer from this problem. The incidence can be higher as female advance in their reproductive age to reach about 1 in 4 or 25% at age 40. So what are the reasons for this recurrent pregnancy loss? This slide illustrates that in almost 50% of cases, there is an underlying reason that can be detected usually by blood test and radiological testing like ultrasound, X-ray with a dye, etc. And obviously, if you find a reason, you direct your attention to treatment of this underlying etiology, okay, and hope that you correct the problem. Unfortunately, in 40 to 50% of cases, we don't find any underlying reason based on the workup and the tests that we did. And as you may imagine, this is very frustrating for both couples and physicians. Because if you don't have a reason, how do you fix a problem? When we reach to that situation, there are few choices for such couples. One choice is to keep trying to conceive and hopefully the problem corrects itself, but obviously at the expense of the emotional distraught if miscarriage happen again. The second option is based on the assumption that a lot of patients with this quote-unquote unexplained factors for their recurrent loss could be actually representing increased incidence of chromosomal abnormalities in the fetus during this pregnancy or in the embryo during this pregnancy. With that assumption, there is a lot of reproductive endocrinologists who are now offering in vitro fertilization after testing the embryos, and you can see that this is illustrated here. This is a nice looking embryo that can be biopsied by taking 10 to 15 cells of that embryo, freeze the embryo, subject the tissue that was biopsied to testing, and obviously if you find 1 or 2 embryos that are chromosomally normal, these can be put back and hopefully solve the problem. Unfortunately, this is expensive and it doesn't guarantee success, and most health insurance unfortunately don't cover it. Therefore, there is a lot of people in our field that say, no, that's not the right way, maybe just wait. And in fact, there are some studies showed that just waiting and expectant management can be as successful as expensive management like in vitro fertilization method, and actually had a lower median time to pregnancy. It happened faster. Finally, in these circumstances, what's being offered is to see a reproductive immunologist to find out whether the immune system of the mom is attacking this pregnancy and leading to the loss. And although that may be a good idea, In certain situations, it's not the ideal in all cases because the test available to diagnose such immunological reaction is of limited value and not that sensitive or specific. And furthermore, the treatment, which is expensive and not covered by usually health insurance, is no guarantee that it will work. So you can imagine when you give this information to the couple, where do we go from here? Very recently, we published this paper that addressed the role of what's called diagnostic hysteroscopy in the diagnosis of subtle anomalies in the uterus that can lead to recurrent pregnancy loss. Actually, I've been working on this for more than 15 years. And what we observed is that routine testing that usually done to determine whether there is a problem or not, namely ultrasound, especially what's called 3D ultrasound, which is believed to be the gold standard and the way to find out about these anomalies, is not really a gold standard and it's not as sensitive and can miss a lot of pathology. And I'm just going to show you some pictures. So here is a patient that the ultrasound showed very subtle issues that would be read as normal, but when you look inside the uterus by a scope, that's what the hysteroscopy is. You can see different. You can see that there is a significant pathology, and in turn, basically you found the reason now that the ultrasound didn't pick. Same thing happened for another anomaly called significant arcuate, very similar. There is a slight heart shape that the ultrasound is not picking, but that hysteroscopy or scope can determine that there is a pathology here. This is what we use for measuring that dip from the roof of the womb to define whether you have this problem or not. And that's how we fix it. It's a very simple procedure. You basically divide that ridge that's present in the fundal area or the roof of the womb that can be leading to miscarriage, because you could see there is a lot of scar tissue there. That's that whitish area that we cutting. This is not a very healthy area for implantation or for pregnancy. And actually, just showing you here another case. You can see the scope, the finding here, and how we divide that ridge and how the end result is. In other words, now the cavity of the womb is in a better shape to allow pregnancy to continue. Here's another situation. This is basically the video that I would like to show you. So in this video, you can see a live surgery in which the diagnosis of this, what's called short incomplete septum, was determined. And we are moving on at the same session of correcting that. And you can see it's really very, very simple procedure, obviously in experienced hand, that you take this ridge down as illustrated here by using a device with what's called monopolar cautery to divide that ridge and basically flatten the roof of the womb to make the cavity of the womb more normal and get rid of what's believed to be the reason for this quote-unquote unexplained. But you could see now by hysteroscopy, by that scope, the unexplained is now explained and it can be corrected. And very briefly, this is, and I don't want to, those who are interested can actually look this paper up. This is the overall population, and this is the two types of anomalies. One is called incomplete septum and the other is significant arcuate. And basically, it's showing that on ultrasound, the measurement is markedly underestimated compared to the real measurement during the scope. And the conclusion then from this study, that the data from this study suggests that 3D ultrasound, which is believed to be the state of the art and the gold standard by almost everybody to make the diagnosis of this condition, is actually underestimate these lesions, and in turn, it's not as gold standard as everybody think. And a diagnostic hysteroscopy, which is the surgery I just showed you and discussed with you, should be part of the workup for any patient who we're told she has unexplained recurrent pregnancy loss. Unfortunately, that is not part of the workup until now. So really the important message then is fine. You find out that there is a subtle anomalies of the uterus. You find a reason for this recurrent miscarriage. What do you expect if you fix it surgically? And this is a published abstract from our group showing the outcome after dividing that ridge or septum after surgical correction. And I'm just going to briefly show you what happened, and that is, you can see the pregnancy rate, and that's great, obviously. The miscarriage rate went down to what you see in normal population, and the delivery rate is here, and the best outcome birth rate. So basically, in summary, about 50 or 60% of the patient, depending on what anomaly, uterine septum or significant arcuate, is to be expected to have a live birth after diagnosis of this issue and correcting it surgically. The conclusion from the latter study is excellent reproductive outcome can be expected after hysteroscopic surgical correction of such anomalies of the womb in patients with unexplained recurrent pregnancy loss. Thank you very much.